Okay, let's talk about something that can be, well, pretty overwhelming. Choosing the right anesthesia for spine surgery. There's a lot of jargon, a lot of fear, and, it feels like there's conflicting information everywhere. So let's dive into this and build a really clear framework so you can make the absolute best decision for your body. And let's be real. When you hear a phrase like awake spine surgery, it doesn't exactly make you feel calm and relaxed, right? It sounds more like a challenge, like a test of how tough you are. It's a line that immediately puts your guard up. But here's the thing. What if that whole awake versus asleep debate is framing the problem in completely the wrong way? What if there's a much better, way more practical question to ask that'll lead you to a safer and, frankly, more comfortable outcome? So, this is the secret. It's the key to the whole thing, really. Most people get this wrong. You are not making one big, scary decision. You are actually making two separate, totally distinct decisions. And once you get that, everything changes. All right, so this brings us to our first really big idea. The real decision isn't just about being awake or asleep. No, it's about separating the how of the surgery from how you're going to experience it. So think of it like this. On one side, you've got the surgical approach. This is what your surgeon does. Are they using an endoscope, a microscope? That's decision A. Then, on the other side, you've got the anesthesia plan. This is all about your experience. Are you going to be lightly sedated or fully asleep? That's decision B. And this is where almost everyone gets tripped up. They smush these two separate things into one giant decision. So why is separating these two things so incredibly important? Because the goal here isn't to pick the option that sounds the most hardcore or brave. The real goal is to find the combination that safely fits your specific medical needs and what your team is set up to do. Like the slide says, it's about your body's constraints, not about bragging rights. Okay, so now that we've got our thinking straight, let's learn the lingo. Let's decode the actual language you're going to hear from your medical team, because understanding these terms is what empowers you to ask much, much better questions. You're probably going to hear the term MAC thrown around a lot. It just stands for monitored anesthesia care. Basically, think of it as a really sophisticated IV sedation. You're breathing all on your own, but you're in this calm, super drowsy state. A lot of people call it twilight sedation, and odds are you might not remember much or anything at all when it's over. Now, I love this line because it's so true. Twilight isn't just some on or off switch, it's a dial. Your anesthesiologist is constantly, actively adjusting your level of sedation based on what your body is telling them. And that's exactly why two people can have the same max sedation and have totally different experiences. Okay, so then why would anyone go with general anesthesia? Well, it usually comes down to one simple word: control. When you're lying face down for a delicate surgery, making sure your airway is 100% protected and that you are perfectly still is absolutely critical for safety. It's not about bravery. It's just a practical choice to manage risk. All right, we've separated the decisions, we know the terms, so now let's bust the biggest myth out there about who's a good candidate for that lighter twilight sedation. I mean, everyone just assumes the key factor is pain tolerance, right? That to be awake, you just have to be tough enough to handle it. But is that really what determines the best and safest plan for you? Nope, not even close. For so many patients, the single most important factor is what we call position tolerance. It's simple. Can you lie completely still, face down, for 30, 40, maybe 50 minutes without fidgeting or coughing or feeling like you have to move? That's the real question. And there's this perfect story from the source material that just nails this point. A patient, she wanted to be brave, she wanted to pick the awake option, but she was a little worried, so you know what she did? She tested herself at home. She laid face down on the floor, set a timer, and after only 12 minutes, she started to get restless. Not in pain, just fidgety. So at her consultation, and this is the brilliant part, she didn't use vague words like, "I'm anxious." She gave the surgeon cold, hard data. She said, "I can't comfortably stay face down without moving." And the surgeon said that was the most useful piece of information he'd heard all week. Why? Because it let them build a plan based on her body's reality, not just a desire to be tough. So how do you figure all this out for yourself? Let's make this super practical. Let's build what we can call your personal anesthesia fit filter. This checklist right here, this is your homework. First, test your position tolerance. But you also have to consider these other critical factors. Do you have sleep apnea? That completely changes how they manage your airway. Severe acid reflux. That's a huge safety issue. A history of getting really nauseous. Your team needs to know that ahead of time to build a better plan to prevent it. And listen, this part is so important. Don't bury this information. Don't just wait for the doctor to ask you about it. You need to lead with these conditions. They are not minor details. They are foundational to building the absolute safest anesthesia plan for you. Okay, you've done your self-assessment. You know your body. Now it's time to arm yourself with the exact questions that will get you the clear answers you need when you go to your consultation. This is the big what-if question, isn't it? The one that keeps people up at night. What if you try the lighter sedation, but you just can't tolerate it? What happens in the middle of surgery? Well, this is where a professional, prepared team really shines. You need to ask about the conversion plan. And let me be clear, this is not a sign of weakness. It's a sign of a really smart, prepared patient. Ask them, what are the specific triggers for switching to general? Who makes that call? How often does this actually happen here? And what does that mean for my recovery later? A good team will have clear, confident answers for all of this. Ultimately, you have to remember this. The best technique isn't really the point. The safest plan is always the one where the surgeon, the anesthesia team, and the facility are all completely aligned and working from the exact same playbook. It's a team sport. So as you prepare, as you get ready for your surgery, just ask yourself this one final question. Is the plan you're thinking about built to give you bragging rights, or is it built to truly honor the unique needs and the real constraints of your own body? The answer to that will always guide you to the safest decision.